Welcome everyone to the Seeing is Believing Southeast Asia and Western Pacific regional webinar. So my name is Neve Brown and I'm Seeing is Project Officer. Thank you all for attending today. So today's webinar really is about shining a spotlight on the impact that SIB has had in two countries specifically. So we're going to look at China and India, and we have fantastic presentations lined up for you today. So firstly, we have Drew Keys, who is IAPB's Program Manager for the Western Pacific region, and he's going to give us some introductory remarks in a minute. And then we'll have a presentation from Kuldeep Singh from Seva Foundation. He's the Program Manager for India and Bangladesh, and he's going to speak to us today about SCALE, their SCALE project. That will be followed by another short presentation from Ni Ming from Fred Hollows Foundation, who will present on the impact of their comprehensive eye care project in rural China. And then after these presentations, we will have time for some questions. And Sally Crook, Seeing is Believing Program Manager, will give us some concluding remarks. So that's the outline of today's webinar. I'm going to hand you over now to Drew Keys, and Drew will talk to us a little bit about what does stepping up eye care services mean to him and to the wider IAPB membership.
In my very first trip for IAPB, I was lucky enough to travel to Shanxi to visit the SIB Project in Taiwan. And so in some ways, when we think about stepping up, for me, it has a very personal connotation, because I was stepping up into the IAPB role and I was actually visiting my first project on that particular trip to China. I was also very, very lucky last year to visit Ni Ming in Yunnan and to see firsthand some of the work that has been done by the SIB project there and the Fred Hollows team and the various partners in Yunnan province. And so I do have a very good understanding of the work that's been done by the SIB projects within the region. I think it's very interesting to note that the reason I would travel to Shanxi on that very first trip was to attend the first National Eye Health Conference that was held by the National Institute of Hospital Administration in China. One of the reasons they chose Taiyuan to hold the meeting in Shanxi province was because of the SIB project and because of what that project represented. It represented collaboration, it represented partnerships, it represented the collection of data and knowledge, it represented bringing together such a variety of partners and stakeholders, from NGO partners international, NGO partners domestic, the local hospitals, the local ministry, the national ministry. And so when I think of stepping up in the SIB context, I really think of that as an example of what these projects can bring to the eye health sector within the region and of course globally. When I think of stepping up, I also think of the amazing SIB team, and I'm going to embarrass them a little bit this evening because we know that the SIB programs are starting to close out. But I really do think of the work that they have done, the incredible amount of information and programmatic knowledge that the SIB team, led by Sally Crook, but with others such as Neve and Susan and Sarah in their capacities through SIB over the many, many years of the projects. I think of the work that they have done, the knowledge that they've added to the sector, the collation and dissemination of data that this team has been involved in. It has been so important to our sector. And you see that work around partnerships and collaboration flow through into documents like the World Report on Vision. So I'm very, very excited to thank the team for their contribution and for their work over the period of SIB projects, and to let them know, and all of you know, that that work around partnerships and integration has certainly been added to the global advocacy space. We will be seeing it in the coming years as we roll out World Report on Vision launches across the region. We will be seeing it through the work that has been done around integrated people-centered eye care, which is of course a new buzz term but it's actually quite a proven concept that we have seen through the SIB projects over the years. So you will hear a lot more from us at IAPB over the coming years. You will see a lot more of us through the rollout of these projects and through the continued implementation of the learnings that have come out of the SIB project. I'm going to hand over now to our speakers, who of course know a lot more about the intricacies of their particular projects. I'm really excited to hear what stepping up means to them. I've touched on a few things that I hope are as important to them as they are as important to the IAPB team and the broader global SIB team. So again, thank you very much for having me this evening, and I'm sure you will all enjoy the coming presentations.
Thank you, Drew. Thank you. That was a really good introduction to get us started and really set the scene and the context, and as we engage and listen to these two really exciting presentations that we have. Great that everyone is introducing yourselves in the chat box. It looks like we have a good global representation today, so that's always good. I'm going to hand you over now to our first presentation from Kuldeep Singh, who is Regional Program Manager at SIB Foundation, and he is going to talk to us today about their SCALE project, which is part of SIB's Global Site Initiative. It matches high-performing mentor eye hospitals with mentee hospitals that seek to improve. So Kuldeep, over to you.
Thank you, Neve, and thank you, Andrew, for giving a wonderful context of what stepping up means. And I also started knowing about eye care through some of the SCALE project joint learning meeting. So thanks to the SIB for providing these wonderful opportunities and also letting partners to share and collaborate on the different learning. So what I'm going to present is the learning that we have from the SCALE program, which was supported by SIB. And if I'm allowed to share my screen, yes, you should be able to see the presentation here. So this program was implemented in India from 2016 to 19. And I will quickly run through all of you to the basic contextual information, like in India, what we work on and things around that. So India is one of the country with the largest number of people living as blind, and also there is a lot more people as a visually impaired. Some of the information I pulled out from the very recently conducted national survey on blindness and visual impairment, and you see the cataract still continue to be the leading reason. Close to 5 million people are blind, which was much higher in 2006 and 7. That was close to 12 million. So there is a reduction in number of blind people, but still there is a lot to deal with. And if we compare the current CSR's cataract surgical rate in India, we are somewhere at 5,000, and we are expected to reach somewhere at 9,000 to cater the avoidable blindness that we are having in different region and state of the country. So a brief introduction to the SCALE, as you have wonderfully mentioned. SCALE was part of the program called Global Site Initiative. That is a network of hospitals across 20 countries. We focused on India part under this program. And it has a model that work on the mentor and mentee hospitals. So mentor hospitals are high performing hospitals that work very closely with the mentee hospitals, and the whole project was designed and implemented in very close collaboration with our mentee and mentor hospitals. I would use partner hospital for them going forward. In brief, SCALE is the acronym for strengthening capacity and learning to effectively deliver eye care. So SCALE is a name that we wanted to deliver actually, and this happens in this project. There were close to 6 mentors I'll be sharing a little bit brief about them going forward, and 56 Mentee hospital spread across 15 states of India. And this is a very dynamic and mutual cooperation where the mentor and mentee hospital work on utilizing their strength, the human resource strength, best utilization of existing resources, and working on the quality of the services along with huge focus on the financial viability and financial sustainability. So these are some of the, what you see in the map is the partner hospital spread across the country, and the 6 mentor hospitals very well known for their work and the wonderful contribution to the eye care they have made. And they were grouped along with on an average 6 to 14 hospitals based on their skills, capacity and strength, and along with their existing relationship with the partner hospitals. And they were working very closely on almost regular basis in mentoring, consulting, and there were certain component of this process. I will try to cover some of them in the discussions that we are having. So SCALE focused mostly on the 4 key interventions that included the hospital diagnostic, which included a lot of focus on the identifying the need of the hospital, developing a plan to address the gap that was more intensively done in the beginning of the project SIB. And then there was a huge focus on the training and coaching. So mentor hospitals had those skills and expertise to share with the mentee hospitals. And also when the project continued to implement, there was a lot of joint learning meeting. You will listen a little bit more about them, and where there was a communication collaboration about learning and their experience sharing happening along with the project. There was a lot of focus on increasing the patient demand that mostly happens through trying to identify the unserved area, as well also increasing the efficiency of the system to deliver the surgeries, to deliver the spectacles, and working around those parameters. And the last but the most important one was the system strengthening, which is mostly around developing the capacity of the hospital to deliver these quality and high volume care. And these intervention were further divided into 6 program area, and 6 that included the need assessment and action planning. I briefly mentioned in the diagnostic part. There was a lot of focus on the installing IHMS and data, so I'll briefly share about that. There was some seed grant available through the program on the where the most critical need were identified across the partner hospital, along with investment in the primary eye care vision centers, and then focus on training, mentoring, and consulting process that I'll be briefly able to share. So before I go much in detail, I'll quickly cover what was some of the deliverables that project was able to achieve at end of the 2019. Some of these information come from the external evaluation done. So close to 29%. This was the average increase of the cataract surgery done by the partner hospitals over the period of time, and this is the increase in their capacity from where they started. In terms of the sustainability, there was close to average 30% increase in the revenue in the new hospital. So there were some hospitals already part of GSI, but the new hospital who joined us along with the SIB project, this was the revenue increase. And then 65% hospitals, there was 65% increase in terms of the acceptance of the surgery and spectacles. So over the period of time, partner hospitals actually done over 1 million surgery in 15 states of India. New primary eye care vision center were established, close to 21, which deliver these services, and 74% of our partner hospitals were able to achieve the WHO post-operative visual acuity standards. That was also one of the deliverables that we achieved. We also focused, apart from many other areas, we focus large on the gender equity as well, because SEVA do believe equity in providing services. And although hospitals were spread in the states where the socioeconomic indicators are not very well, especially the underdeveloped state, but still we will manage to have at least 50% women in 59% of the participating hospital, and close, if we see the number of women more than 48% in each hospital, that figure goes somewhere around 70-75%. Huge focus on sustainability, as I already mentioned, and lots of training and capacity building. 752 were the number that were intensively focused for long term, but there were many other short term training done by the mentor hospitals along with the project time period. And partner hospitals saw over more than 3 million patients in this time. So what we saw is 90% increase in the acceptance and surgery due to the project. And this is information coming from the external survey that was filled by the partner hospitals, and 100% of them recommended scale like mentoring program if they have a chance to recommend it to the other partner hospitals. And there was a huge change in the mindset of the partner hospitals thanks to the consulting and mentoring skills of our mentors. They realize the mindset change is one of the biggest achievement going forward to improve the efficiency. So before I go to the details how we did and what happens in the process, I would like to share a direct experience from one of the mentee hospitals, and let's hear from him, and then we can go on more into the details of the strategies and learning.
Very warm greetings to all. We are very thankful to Seva Foundation and SIB Webinar Standard Chartered Bank program to support the SCALE project, which is an idea carried through the Global Site Initiative program. I've been very fortunate to work initially in the Central India for the Global Site Initiative, and then moving to Eastern India from 2017 and working for the GSI at SCALE program. Indeed, the SCALE program is unique for every mentee hospital, having the guidance of mentor hospitals, the stalwarts working in the mentor hospitals. And one of the unique features, which I must say, contributed to every mentee hospital is learning about the gender equity. Addressing the gender equity, providing the eye care to the females as they are neglected. Addressing further the sustainability part, the capacity building part, training in particular for the mid-level ophthalmic personal life, ophthalmic technicians, OT technicians, and giving them a physical hand-holding training to move further, addressing the quality comprehensive eye care services. I say this as partnership with friendship, learning from different mentors, different mentees, having their challenges, strength, weakness. I also say this is a learning with a collaborative, communicative, joint effort, and moving ahead to provide good services to the needy patients in every part of the country. Thank you very much.
Thank you so much, Dr. Rajesh, for putting these learnings into the perspective from the mentee hospitals. And as we go along, these are some of the SEVA strategic priority area where we also focus in the GSI, Global Site Initiative, as well as in the SCALE program, working around the access, reaching to the unreached, working on the demand side of the overall eye care, building the capacity through training, through development, through mentoring, and then a lot of around evidence and data and research. I'll be briefly sharing a bit about it while going forward. So in terms of the evidence and data, SEVA from the very beginning were very clear. If we can't track something, we can't manage something. So these, all the parameters that we have highlighted across this presentation, they were built into our reporting platform from the mentee hospitals, and they were able to see these parameters tracked in their quarterly reports, along with some of the partner dashboard that we made through actually the SIB investment, and that is still available for the GSI partners going further. There was a lot of focus on building long-term institutional capacity building. Mentor hospitals work along with their own expertise, their own relationship with the existing hospitals. And it is not a one-time or one-year investment that we are making in the Minty hospitals, but it's a close collaboration, and we continue to still invest and work with the same hospitals even after the SIB project. Knowledge and collaboration is something that Dr. Rajesh has highlighted, and it will be something that comes across all the Minty hospitals, because we see learning as a very agile, very adaptive, and it happens in the real scenario on everyday basis. And that's where the model of the Minty and mentor hospitals doing lots of joint learning meeting, sitting together with each other, sharing their own experiences of failure, of success happens in the project. Lot of investment on the capacity building through the seed grant, as well as the learning management system that SEWA has built through the investment of SIB for the GSI network. We did focus hugely on the servicing the marginalized communities in the rural area, the women that you already have seen across the parameters, and then investment in the human resource and capacity of the hospitals for the long term, not just for this project, but serving these people for the long term in the area where they are working. So without further ado, I would quickly wrap up some of the important aspect, and I will leave some of this time for question and answer. But going further, I would like to highlight some of the actually best learning and some of the most admired contribution of the SIB fund and through the scale was technical partnership and knowledge building. So it was a body of knowledge that was built across the time, which will be used through the GSI network hospital in the following years. Investment in the vision centers, teleophthalmology, investment into the technology, and having a space for innovative space and investment in the digital, and as well as the different healthcare space where we didn't realize how technology will be helpful, but considering what we are facing this time, including the pandemic, these investments have been super helpful, especially the teleophthalmology investment in vision centers and in the partner hospitals. Thank you, New, and over to you.
Thank you, Kuldeep. That was a really comprehensive overview of the impact brought about by the SCALE project. The project definitely lives up to its name. Partner hospitals performing over 1 million cataract surgeries. It's really impressive, and it was really great to hear from the perspective of the partner hospital too. I think this mentor-mentee model it's really exciting, and not just because of the peer learning aspect, but also because of its potential for sustainability post project closure. I think it's really, really interesting. So thank you very much for that very insightful presentation. Just to remind everyone, if you have any questions for Kuldeep, please type them in the box, the chat box as we go along, and we'll get to them at the end of our presentations. But now let me hand you over and introduce you to Niming, who works for the Fred Hollows Foundation as the project manager, and she's based in China. And Ming is going to talk us through a project funded through phase 5 of SIB called A Comprehensive Rural Eye Care Model in Yunnan Province. Ming, over to you.
Thank you, thank you very much. I will share my screen.
Great.
Did you see my screen?
We can.
Yeah, thank you offer this opportunity to us to sharing our experience from our Saving Easy Believing Phase 5, a comprehensive rural eye care model in Yunnan Province. In this presentation, I will introduce the first is the brief of the project, and the second is what's the success, experience, and the lessons learned, and also based on those Saving Easy Believing project we implemented in China. We developed a comprehensive rural eye care model. I will have some introduction for this model. This project is called a comprehensive rural eye care model in Yunnan Province, increasing access for disadvantaged group to universal eye health in China. And in this project, we mainly implement project in Yunnan in 2 prefecture, 4 counties. And this is a more than 3 years project. Impact by this project we think is a comprehensive rural eye care model was established with concrete operational manual developed to provide accessible quality eye care services for community people in rural area of Yunnan province. And I just list some successful experience. I think the major important lessons learned and experience is multi-sector engagement and cooperation. As mentioned by Zhu previously, in China, we need to have very strong collaboration and relationship with the local government, so we can ensure those project activity can implement very smoothly. And also, you need to involve them in the different stage of the project development, such as project development, project implementation, monitoring, and evaluation. And that is set up the foundation to have some sustainability of this project. And the second success experience is we integrate our primary eye health to primary healthcare, which including the school eye health. In this way, for example, in the training, we integrate our primary eye health training curriculum to the primary healthcare training, which provided by the local government. And also for screening, because in China, we have the public health project, which is funded by central government. And in that, there is one activity related to the eye, which they need to establish the health record for each community persons. So because in that activity, they have the vision acuity check. So we provide this kind of training and to ensure this vision acuity check quality. So they also can continue to do this when the project finish. And also, for the school eye health, we provide the school teachers training, and also we train them to how to do the school eye health education, not only for the students, but also for their parents. So we want to build the supporting environment for the myopia control and youth eye health in China. And also we develop some training manuals. You can see, for example, the cataract surgical training manual, which including 2 books. One is target for the organizers, and one is for the trainees. So based on that, they can use this manual to guide them how to do how to organize the cataract surgical training and how to do the hospital-based cataract surgical training. And also we developed the school eye health training manual. This is applied participatory approach to use entertainment education method to teach teachers how to use some games, role play, and songs to demonstrate or interact with the children to introduce the eye health knowledges. So this is manual. This year we just cooperate with the National Blindness Prevention Committee. We jointly published this manual in China. And also we developed the primary eye health training manual. This is very straightforward ways. The village doctors or community health workers, when they got this manual, they can use this very clearly guidance to introduce once they identify some syndrome and what's the flow they can use to decide whether this patient needs to refer to the higher level, or which they can treat it by themselves, or they can refer it not very urgently. And also this year, we cooperate with the Zhongshan Ophthalmic Center. We developed this online course. We want to increase the coverage of this training, of this primary eye health trainings. And also in this project, we also focus on the diabetic retinopathy. One challenge we face is limited communication between the ophthalmology department and the endocrinology department. So based on that, we developed the DR training manual for endocrinologists. So we want the build very good referral pathway between these two departments. So the patient in the endocrinology department, they will have a chance, and also they can they will be referred to the ophthalmology department to have the regular fundus check. And also based on those good experience, we developed the comprehensive rural eye care model. We call it 1, 2, 3, 4, 5, 6, 7 model. And this model is based on the project experience and addition to the practical evidence. And also this model is not only based on this Yunnan project, is also adopt a lot of lessons learned and successful from our FHF, the Fred Hollows Foundation China program experience in the other project. And this project strategy and approaches are understood and supported by the governmental, the provincial and the local health authorities and our partners. And also this is consistent with the national health and education policy. And you can see in my presentation, this is a diagram of our comprehensive rural eye care model. 1 stands for the theme, we do the eye health. We want to eliminate, avoid blindness and vision impairment. And 2 means 2 capacities, and this is 1 is for the professional eye services and the management capacity, and another 1 is the primary care capacity. And the 3 is means 3 outreaches, because in China in the past, a lot of doctors are waiting in the hospitals. They don't go outside to find the patient. So in our project, we introduce the outreach approach, and we go to the village, rural area, and also the communities and the schools, so they can access the service at their home. The 4 means the 4-level system, provincial, prefectural, county, township, and village. We want to build a very function referral pathway, and also capacity building and technical support network. And 5 focuses, we focus on the elderly people, women, children, life behind people, and people living in vulnerable situation, and people with special needs. 4 enhancement is more with WHO's health system strengthening the 6 building blocks. And for 7 actions, including the training, provision of medical equipment, screening, treatment, and health promotion, research, and advocacy. And in order to implement this model, we summarize the 10 conditions in 3 dimensions. 1 is the supporting environment. For example, the leadership, the policy, and the governance, and the research. And the second dimension is the health system strengthening the resource resources allocation to the grassroots level, human resources capacity building, system building, and service delivery. And for the last dimension is the public awareness raising on health. So if you only provide the capacity building or build the policy environment is not enough. We need the people to understand their own needs, and they're aware where they can access this services, and we need to help them to remove the barriers they faced. And also the multi stakeholders participation and the mental health. And this diagram is the before we implement this comprehensive rural eye care model. You can see in the first half, above the diagram, you can see is the top-down triangle. So that means the most resources and patients are willing to go to the provincial level hospital to get their eye disease diagnosis and treatment. They don't trust the lower level, for example, the county level or township village clinic level capacity to provide the eye health, and also they also in this level the capacity of eye health is quite low. So and also you can see in the above in the bottom of this diagram, this is from the community perspective. The awareness of the eye health and awareness of the eye health seeking behavior is quite low. So based on this challenged situation, we developed this model. So you can see this diagram is about after we implement the rural eye care model. So you can see in the provincial level hospital, we provide their role in this project is the coordination, management, and provide the technical support or provide the trainings to the lower level hospital, and have some research in this level. And you can see the major service delivery, the major service providers in this project is the prefecture level and the county level. In these two levels, the project provides, for example, the training equipment, outreach screening support, and other management trainings to equip them. They can provide the for example, the cataract surgeries, refractive error services, and also diabetic retinopathy screening and laser treatment. And also down to that level, the township village clinic level. In this level, we want them to provide the primary eye care services, for example, the screening, public education things. Based on this input, they have their very clearly roles and responsibilities in our full level PBL network. And so you can see in the right hand and the left hand, name the resource and the services. In the previous diagram is only in the provincial level and the prefecture level, but after the project, their resource and the service is down to the township level and the clinic level. And you can see the green and green. This is three disease we focus on: the cataract surgery, cataract, diabetic retinopathy, and refractive error. And you can see we have the multi-sector cooperation. For example, the Women's Federation, and also a Disabled Persons Federation, and a Health Commission, and also we cooperate with the local government. So you can see we increase their awareness of the eye health and health care seeking behavior. And this comprehensive rural eye care model we apply to the remote and the poor ethnic area, which medical resource is very limited, and their eye health needs are not sufficiently met. And also, you know, in China, we have the diversity of the grassroots. We keep it in mind, and also the national demography and health system context. If we replicate this model, we will tailor to fit to the local needs and the situation. And this model is not one that is not this model is an evolving model. We will add new component or new activities or new strategy if we have some different context or special needs from different project sites. And also this can be contextual contextualized for different environment and the context across China. When we promote this model, we divide the two levels. The first level is the project partner level. We demonstrate and recommend this model in the project final review meeting. And during that meeting, we also invited some non-project partner to participate in this meeting. After the meeting, they show the great interest to replicate this model in their counties and also want to support technical supports from the Fred Hollows Foundation. And from the national level, we take every opportunity to recommend this model, for example, in the National PBL Training Workshop and also National Eye Health Conference. Last year, we have this National Eye Health Conference, I think, in Xi'an. After our session, one hospital in Shanxi province, they approach us. They want to replicate this model and have some consultation from us to how to replicate some parts of this model. Thank you.
Thank you, Ming. That was a really interesting presentation, and I'm struck by the adaptability and the potential to replicate the model across China, which is really significant, and the really unique success you've had in reaching the most marginalized, adapting the quite a multi-layered approach, and the success in kind of focusing on village and township level. Really interesting. I'm a big fan of your 10 conditions for success as well. It makes you realize that there isn't one silver bullet here, and a comprehensive rural eye care model requires lots of different elements. Thanks again for your presentation. I'm going to open up for questions now, so please feel free to type in the chat box. I see that some of you already have been putting your questions in, so feel free to add them, and we'll answer as many as we can. To kick us off, we have one here from Parami, and it's for you, Kuldeep. What would you say is were the biggest challenges that you faced in running SCALE?
Thank you for the question, Parami. One of the things I realized, there is no one prepared solution for all the problems. So as you see, there were different regions involved, so many different type of mentor and mentee group working together. So I would say challenges were more into some of the challenges that we share is common around is data. So because there is no data, no evidence, no reports available, tracking the performance was a difficult thing to start with. So that's why one of the focus area we started with was with the data for women, data for cataract surgical rate, data for conversion rate of the surgery advised against surgery accepted by the patient. So having this model and data available for tracking these parameters was one thing. Second was, there is a specific need of each mentee partner. They are from different area, different region. So the mentors were super efficient in addressing those challenges during the course of the program. And most of the challenges we realized was more specific to the group of people where we work together with the mentee hospitals and the mentor hospitals to address them. But also one of the things I want to mention is the mindset. If you have a mindset to serve the people, many other things might find a way towards solution.
Really interesting. Thanks, Kuldeep. We have another question from Dr. Leela. What were the strategies undertaken to improve the surgical skills? So I'm not sure if this question is maybe Kuldeep. Can you answer this?
Yes, thank you. Thank you, Dr. Leela. So, I mean, it's a big area to address in terms of the quality, and also you see the data, cataract surgical complications are still higher, a lot higher, even after all these years of intervention from different stakeholders, including the government. So I would share one of the example, and there are many more examples like this. There is no one particular solution, but what I really find very useful was mentors organizing these annual visit to the Mentee hospitals, where, for example, the Aravind did visit to the Mentee hospitals, where I was also able to join them. So few days visit has a team of the expert doctor, medical director, someone from the administration who know the administrative issues of the hospitals, and they were spending time with the Mentee hospitals for a few days in their hospitals, working around them. Where is the problem? So there was a lot of training and capacity building around the standard operating procedure in the clinical area, but also having someone as an expert to be able to be with you all the time during day and night, and to see where you actually need the improvement. So this was one of the many example I would say that it help improve the surgical skill. But I also want to highlight each mentor had their own processes and strategies to help their mentee, because they knew them very well. And this is one of the strong point of this model. We don't apply one solution to everyone. Thank you.
Really good, really good. Ming, a question for you. How many cataract surgeries were done at locations other than provincial hospitals during this project period? And how much was the CSR and how much was the improvement? What is the surgical procedure covered in the training and training manual for cataract surgery? FACO or 6? I hope I've pronounced that right.
Yeah. Yeah, I think this question is quite good, because in China, even we already put a lot of resources. For example, in this project, we put a lot of resources, efforts in the county level hospital, but in the provincial hospital, they cover large population. So it's also they also have very high volume of the cataract surgery, but compared with before, some simple cases of cataract surgery they can perform in the county level, but some more complicated cataract surgery cases they need to go to the provincial hospital to do the surgery. So I think this is one thing we observed after this project. Yeah, and also you asked about the CSR, because we don't have this kind of research, because in China, for example, in Yunnan, a lot of hospitals can provide this cataract surgery, but we not cooperate with them all, so we don't have access to this CSR numbers in Yunnan province.
Okay.
The last question is about the training surgical procedure. We provide the SICS training approach procedure to our county level hospitals. But in China, because the technology involved, most doctors prefer phaco to do the surgery. So we still have some internal discussion if we can provide the phaco training to them, but not in this project, in the future. Yeah.
Brilliant. Yes. Thanks, Ming. Okay, I think we have time for one last question, which I've just seen here on the side. So this is coming in from Elise, and it's thank you, Kuldeep, for your insightful presentation. Can you tell a bit more about what was in the PowerPoint lessons learned? So vision centers and tele-ophthalmology have multiplier effect. Could you elaborate on that lesson a little bit?
Thank you. Thank you for the question, and I am happy that you asked for such an important part of the lesson learned. So actually, for the paucity of the time, I did skip some of the part around the lesson learned. But what I mean, apart from what is you see was mentioned, so lesson learned around data-driven evidence, capacity building of the hospital, not just the one particular group or team. And then lots of lesson around the collaboration and the knowledge building together and investment into the long-term institutional capacity building. The question about the vision center as well as teleophthalmology. So one of the example and very good example we can see, if we were not investing in the teleophthalmology back then, we couldn't have used them now in the COVID time. So it does have multiplier effect. And when the patient are not, I mean, they are hesitating to come to the hospital, teleophthalmology is a big boon for them to go to the vision center, which is very near to them, which is accessible to them, which will not take much of their time to travel to the eye care facilities, and still 80% of the eye care problems can be solved at the vision center itself, with the consultation available from a doctor due to teleophthalmology at the vision center, as well as the staff available at the vision center will be able to give them the human touch and other needs that a patient would need. So these are some of the example, and I'll be happy to share more if by email or something.
Thanks, Kuldeep. Thank you. Thanks. What I'm going to do now is we have a couple of more questions coming in, but maybe we can answer them when we go offline. But because I'm conscious of time, so I just want to hand you over to Sally Crook, which is the SIB Program Manager. She's going to conclude our webinar for today with some final remarks. And thanks to Kuldeep and Ming.
Thank you.
Okay, hello everybody, and thank you for staying till the end. I've just really enjoyed these two presentations today. I think they have both sort of showcased what Seeing is Believing has achieved over such a long period of time. And I think this is great. And, you know, when Drew started, he was talking about partnership and integration and sort of moving towards the integrated people-centered eye care that, you know, IAPB is promoting now. And I really do feel that both these projects really highlighted the partnership element of things. And I think, you know, in Kuldeep's presentation with the, you know, the sort of the dynamics between the mentor and mentee hospitals, I think we have to remember that I have seen in some of the reports that the mentor hospitals also admitted that they were learning from the mentee hospitals. And sometimes some of these mentee hospitals have had great ideas that can then be shared more widely among both all the other mentee hospitals, but also the mentor hospitals. Also the issue around, you know, what the little video clip showed, which was really about partnership with friendship. That's a big message I got from that. That, you know, for people to learn and want to learn, it has to be very equal and, you know, sharing, and that everybody needs to be in it together. So I think that's just been wonderful, and I thank you for Kuldeep and all the team across all those hospitals, both the mentor and mentee hospitals. You know, it's really been a success. From China, this comprehensive rural eye care model, I think we've really learned a lot. And as some of you might know, Seeing is Believing has supported the Fred Hollows Foundation in other parts of China in developing this model. So it's really had a lot of sort of, you know, learning over the years. But in Yunnan, I think it's really lovely and come together and things. And we've really been able to share a lot of what's been going on. And I think, you know, for all of us, it's been just such a great this now with the 1, 2, 3, 4, 5, 6, 7 sort of model and things. I think it's really helped. But again, at the end of Niming's presentation, I thought we came back to this idea about integration and putting people at the center, and also how, you know, in all the places where we've had Seeing is Believing projects, the issues around things like, you know, gender issues, they keep on coming up everywhere, and how do people get the access and things. So really, you know, having this people-centered eye care is so important. And I think in the Fred Hollows model there in China, it's trying to create this for these very rural communities that often, you know, this is where the elderly live. In all our communities, you know, they're often, this is where the need is. And so trying to get the services to move from the the sort of the old-fashioned top-down approach to a much more people focused, having the people, you know, there at the center right from the start and involved in the planning, and then involving, you know, all your local authorities or your hospital authorities. But again, in China, how, you know, involving the Department of Education and the schools and the teachers and the disabled people's organizations, you know, it's really helped to encourage people to be much more, you know, just aware of eye care needs, and that help is available, you know, that we can provide services, and that, you know, help can be helped, you know, for all the problems that we have, you know, when we sort of crunch the data, so many of the problems, they have, you know, a cost-effective and known solution, and you know, we need to encourage people to take up those services. So thank you to both the presenters today. I thought that was very interesting, and I do hope that people, you know, we will share your questions with the presenters if you have any more questions from them or queries, you know, about this, because I think there's just so much learning, and that's what I'd like to stress about Seeing is Believing. We have had so much learning, and we do hope that the networks that we're starting to create over the years will, you know, be sustained, and that will be another sustainable legacy of Seeing is Believing. Thank you very much.
Thanks, Sally. Thank you. Okay, so that brings us to the end of our for our webinar today. Some of you, just want to note, some of you might have already seen in the last SIB newsletter, we are organising a final programme closing event on December 1st, virtual event. So please do save the date. It's sort of the last opportunity for SIB partners to come together to celebrate successes, share learnings, and discuss kind of potential opportunities for collaboration going forward. So I'd like to end by thanking our presenters again, Kuldeep, Ming, Simon and Sally. Thank you so much for your comprehensive presentations. Thank you, Holly, for your technical support again. And thank you to all of you who've participated. We really appreciate you taking the time to be part of the SIB learning community. I have just one final favour. I'm going to email you the SIB survey after this call, and if you could just take a quick 5 minutes to complete it, it really helps us in sort of improving our webinar experience. So that's
and I'm going to jump in here and say I really hope to see lots of you on the 1st of December. I hope you all have the 1st of December in your diaries to come and join us at the SIB closing event. So we hope to see you all there.
Yes, yes, please do. So thank you, and have a great rest of the day, everyone.